Thank you for the introduction. How do I do this? We have no disclosures. There exists growing concern that general surgery chief residents are unprepared for a broad surgical practice at the completion of residency. At this time, 80% of general surgery residents choose to pursue further fellowship training upon graduation. Moreover, a recent poll of surgery fellowship program directors found that 25% of graduating chief residents are unable to operate independently for an extended period of time. These issues are obviously multifactorial, but are likely related to decreased operative experience during residency and increased complexity of operations. With regards to increased complexity, minimally invasive surgery has become the standard approach for many common general surgery operations, including appendectomy, cholecystectomy, and hernia repair, among many others. At this time, 37% of major general surgery cases logged by residents are laparoscopic. In 2008, our group had demonstrated an upward shift in basic cases traditionally performed by junior level residents. At that time, the surgical community responded that the distribution of cases away from junior residents would likely normalize over time. The purpose of this study was to determine if redistribution of basic operations to junior residents has occurred since our initial study. We hypothesized that the trend of decreasing junior resident operative experience would resolve over the subsequent 8 years, from 2005 through 2012. Data for this study was collected from the American College of Surgeons NSQIP participant use files from 2005 through 2012. We included laparoscopic and open appendectomy, inguinal hernia repair, and cholecystectomy to represent basic cases that were historically thought to be appropriate for junior level residents. Colectomy was included as an example of a more complex operation which we did not expect to change across the data set. Cases were stratified by level of resident performing the operation, with junior resident defined as postgraduate year 1 through 3. Logistic regression was performed to assess the likelihood that an operation would be performed by a junior resident over time. A total of 185,335 cases in the NSQIP PUF files included PGY level. This variable was reported in approximately 50% of cases in the data set. Appendectomy made up 30% of the cases, hernia repair 22%, cholecystectomy 33%, and colectomy 14%. Overall, 66% of cases were performed in laparoscopic fashion across the data set, and the proportion of operations done laparoscopically increased over the 8 years we studied. We first examined resident participation in laparoscopic surgery and found that the likelihood a cholecystectomy or appendectomy would be performed by a junior resident decreased by 6.2% per year and 2.6% per year, respectively. Inguinal hernia repair showed no significant change. Interestingly, junior residents were more likely to perform partial colectomy by 3.9% per year, but these cases are still predominantly performed by senior residents. This graph represents junior and senior resident participation in all laparoscopic procedures we studied. As you can see, cases were evenly distributed in 2005, and each year junior resident participation declined. Next, we looked at open surgery and found a similar trend. The likelihood that each procedure would be performed by a junior resident decreased each year. Cholecystectomy decreased by 4.1%, appendectomy by 9.4% per year, inguinal hernia repair by 10% per year, and partial colectomy by 3.9% per year. This graph depicts junior resident participation for all open surgeries we examined. Each year, junior residents were 6.2% less likely to participate in all open surgery. Finally, this graph demonstrates the decrease in participation of junior level residents for both open and laparoscopic surgery across the 8 years we studied. Junior resident participation has steadily decreased in open and laparoscopic surgery. This study is limited by its retrospective design. We were also unable to determine if total case volume performed by individual residents is decreasing. NSQIP only records the most senior level resident who participated in the case. Therefore, cases of double scrubbing where a junior resident acts as a first assistant were not able to be captured. Finally, PGY year is no longer captured by NSQIP, so unless this changes, a continuation of this study cannot be performed. We conclude that the proportion of common laparoscopic and open operations performed by junior residents is steadily decreasing. This trend was demonstrated for appendectomy, cholecystectomy, and open hernia repair. The observed decline may be related to senior resident unease with common operations. Without appropriate intervention, this issue will likely continue to worsen as residents who operated less as junior residents will feel compelled to operate more as senior residents. With increasing complexity of common operations, residents are now required to learn a larger number of skills and procedures in the same or less time with new duty hour restrictions. Robotic surgery and other technology, including SILS, further complicate the same basic operations, requiring surgeons and residents to gain additional skills. As concern grows that graduating residents are unprepared to operate independently, this study supports that new paradigms for teaching residents to operate throughout residency are needed. Thank you, and I'm happy to take any questions.